Here. Okay. It's on.
So, good morning, everyone. We could start for another CAML Rheumatology series. Also, it has been very common this year, but also on Sjogren. So we're very happy now to host Professor Benjamin Fisher for this talk today. Professor Fisher completed his medical education at the United Medical and Dental School of Guy's and St. Thomas Hospitals in London, where he obtained a BSc in immunology in '96, followed by his MBBS in 1999. His training as a rheumatologist was conducted in London, during which he undertook academic pursuits at the renowned Kennedy Institute of Rheumatology, Imperial College London. He now works at the Institute of Inflammation and Aging in Birmingham, with significant expertise in Sjogren's disease. He has had a relevant experience in several new clinical trials of new drugs in this disease, and will talk to us about the challenges and opportunities in Sjogren's clinical trials. Professor Fisher, it's great to have you.
Right, thank you very much for the invitation. It's a real pleasure to be here. These are my disclosures. So I'm sure you're all very familiar with Sjogren's syndrome, but in case there's anyone who's not, I just want to point out a couple of things. Firstly, although many people have previously dismissed this as being just simply a minor inconvenience, actually for somebody with long-standing Sjogren's syndrome, this is a disease which causes a profound impact upon their quality of life. So you see at the top evidence of an extremely dry mouth that will trouble them, wake them at night with dryness, cause difficulty with prolonged speaking and with eating. This is a very old type of stain called rosebane gall, showing epithelial disruption of the surface of the eye. And that will give them a constant sense of grittiness and like they've got sand in the eye. Again, causes considerable disruption to their quality of life. And of course, they can get carotid gland enlargement, which may in a proportion of patients lead on to lymphoma, and they get systemic manifestations in at least a third of patients. And of course, those can affect a whole variety of body systems. And that heterogeneity, of course, causes quite a lot of problems when we think about clinical trials and how best to assess response. So at the glandular level, again, this is something which I expect many of you are extremely familiar with, but this is H&E stain of multiple minor salivary glands taken from a lip biopsy. And what you can quite nicely see in that is these areas which look darker, and that is the collection together, a focal collection of mainly mononuclear cells that are mostly lymphocytes, and these would be a mix of T cells and also B cells. And in a proportion of these foci, they develop a degree of organization. So they develop B and T cell segregation, as illustrated here. And on this H&E, you can also see a paler area, which shows an underlying germinal center-like structure. Nuclear cells that are mostly lymphocytes. Okay. Okay. Which can also support local autoantibody formation. And there's a little follicular dendritic cell network underlying that germinal center. So histologically, it's a focal lymphocytic cytinitis. Now, thinking about one of the greatest opportunities in Sjogren syndrome is that there are no licensed drugs for this disease, no licensed immunomodulators to target the systemic component. In fact, the only drug that we've used a lot of routinely is hydroxychloroquine. And hydroxychloroquine is a drug that the largest trial now is a few years old, but which showed no effect upon the key cardinal symptoms of dryness, pain, and fatigue in the Sjogren trial. And this again illustrates not just the opportunity, but also illustrates the challenge. Because hydroxychloroquine is a drug that we still use in Sjogren's. I don't know what your practice is here, but we certainly still find it useful, particularly for treating some manifestations like skin and joints. And yet the largest clinical trial that's worked with it has really shown.
You don't see the screen. So we had a technical issue.
No worries.
Okay. Okay. Thank you.
No problem. Is that okay? Do you want me to carry on?
Yeah.
Brilliant. Okay. No problems. And yet there is evidence not just that this may work clinically, but also there are some biological effects with hydroxychloroquine. So some studies suggesting that it does in fact reduce immunoglobulin levels. So you get a reduction in IgG levels, for example. And there's also evidence that it reduces the type 1 interferon signature that we think is maybe important in the pathogenesis of Sjogren syndrome. So some biological effects, but we're not picking it up on the clinical trial outcomes, which in this particular study involved the symptoms of dryness, fatigue, and pain. And we'll come back to you. So that's one of the challenges. How do you design a clinical trial in a heterogeneous disease and in a way that shows good outcomes for a drug that you think will actually work? So I haven't got time to talk into the pathophysiology of Sjogren's in any great detail, but I just want to highlight a few points. So we think that Sjogren syndrome arises through epithelial dysregulation, and that will have a number of effects. It will activate B cells, and particularly through the production of BAFF, B cell activating factor, which will have a role in supporting B cell survival within the tissue. So we believe that B cells are important. We think, as I've mentioned already, that type 1 interferons may be important, and they probably also have a role in driving B cell hyperactivity. And we believe that the way that B and T cells talk together is also important through pathways of co-stimulation. And again, we're going to talk about that a little bit. So in terms of B cells and Sjogren's, lots of evidence of this B cell hyperactivity that we've mentioned. And firstly, you've got anti-Rho antibodies. So you've got autoantibodies, which are show a high sensitivity in patients with Sjogren's syndrome. But you've also got this, what we call a polyclonal hypergammaglobulinemia. So a lot of patients have raised immunoglobulins. There are also these germinal center-like structures capable of supporting autoantibody formation within the diseased tissue. And it's also a high proportion of B-cell lymphomas. It's around 5%. And the majority of those lymphomas are also B-cell driven. And we have these high levels of the B-cell activating factor we've mentioned already. And B-cell activating factor within tissue may prevent B-cell apoptosis. And interestingly, very old data showing that if you overexpress BAFF in mice, then you get a disease which has some features of Sjogren's, some feature of lupus, and a small proportion of those mice, if you leave them long enough, will develop a B-cell lymphoma as well. So a strong rationale that B-cells are important in pathogenesis. And yet, as you are very likely aware, there have been 2 phase 3 studies of rituximab as a B-cell depleter within Sjogren's, and both of those failed to meet their primary outcomes. And the question is, why is that? Is it simply that we studied the wrong patient population? So maybe some of the patients included in the study had disease just too long, maybe they had damage, and there was irreversible changes. Maybe it's an issue about stratification. So there was a little bit of data from a Dutch study suggesting that patients with higher levels of B cells within their glandular tissue before rituximab may do better in terms of their clinical response. So it could be an issue of stratification, although there's some French data which seem to show the opposite. There is this concept that B cells may be protected within a pathogenic niche that I've mentioned already in relation to the production of BAFF. And this is sort of quite nicely illustrated with this data from a Dutch center. And if you look at the top, this is before rituximab, and you've got B cell staining in the brown color. And you still see B cells after rituximab. But the interesting aspect of the B cells after rituximab is they showed an increased rate of somatic hypermutation, so indicating that these B cells are proliferating within the tissue, despite the fact that the patient received rituximab. So it could be that you just don't get sufficient B cell depletion in the tissue. And it could be that there's an issue about the primary outcome, as we've mentioned already with the hydroxychloroquine trial. In both the phase 3 rituximab trials, the primary outcomes were symptoms, which didn't meet the primary outcome. And yet, if you look closely in the French trial, the TIERS trial, at early time points, particularly when you look at maybe fatigue and dryness, there is a little bit of early separation between the rituximab and the placebo group, suggesting that rituximab may be doing something. It's just not having a very large effect, and that effect is lost by week 24, which is the primary outcome of the study. And there are other indicators that rituximab may do something. So one thing we'll come back to right at the end of the talk is the potential use of composite measures. And this is a composite measure which contained a measure of systemic activity, but also symptoms and saliva flow and ocular scores. And this particular study, post hoc analysis of the UK TRACTIS trial did show at week 24 that there was some separation between rituximab and placebo, although the effect is small, but some signals. And there's also a little bit of data from the use of ultrasound. So as you will be aware, if you use ultrasound, it can be quite a useful diagnostic tool in Sjogren's syndrome. And the commonest features is the presence of these hypoechoic or anechoic areas within the glandular tissue. Some other changes you can see, such as hyperechoic bands or loss of the posterior border. But this is a single center sub-study of the French TIER study, where they used a 0 to 4 scale of ultrasound changes in each of the 4 major salivary glands, giving you a maximum total score of 16. And there's a bigger proportion of patients with a 1-point change in that score in the rituximab treated group when compared with placebo. So some indication that maybe these hypoechoic glands are changing. And we also did an ultrasound sub-study as part of the UK TRACTIS trial. So the UK TRACTIS trial had patients treated at baseline and also at week 24 with and 26 with rituximab. And then we did ultrasound, baseline, week 16 and week 48. And again, on a pre-specified analysis, we modeled an improvement with rituximab on a 0 to 12 total ultrasound score, combining various features. So some suggestion based on ultrasound that rituximab may be doing something. It's just the effect is not large and is not having a very large effect on the patient's symptoms, which matter to them considerably. And the thing which has really moved clinical trials forward in Sjogren syndrome, and certainly encouraging many companies to do research, it's the development of the ESDI, which again, I suspect that many of you are familiar with. So this is the Euler Sjogren syndrome disease activity index. And what this does, it's a measure, I guess, of systemic disease activity, looking at 12 domains, and these are weighted according to the size of the bar chart, rather according to the size of the wedges in the pie chart. And there are a number of issues with this. Firstly, it's got a very large score range, 0 to 123, but it's very heavily skewed to the left. So that means that the majority of patients have very low ESDI scores. So in the French assess cohort, although the highest score you could get theoretically is 123, the median score in this cohort of patients was 2. So it's very skewed to the left. That's not an optimal characteristic for a clinical trial outcome. But nevertheless, this has been widely used now. Moderate activity is 5 points or more, high activity, 14 points or more. And the way I think about it a little bit is that we can see in the corner, it's a little bit like a sundial. So sundials can tell the time quite accurately, but if you've got a cloudy day, it may be quite useless. And if you've got a lot of comorbidities and a patient with Sjogren syndrome, lots of other things going on, it may be very difficult to assess their ESDI score accurately. So this is a blunt tool, and yet it has been quite widely used now in clinical trials in Sjogren's. And this is a study which I think you're also working on, the Neptunus studies with this anti-BAFF receptor. And this is an interesting drug because this is a dual mode of action drug. So this drug binds to the BAFF receptor, and it does two things. It blocks the effect of BAFF, which, as we've mentioned, may have a protective role against depletion within tissue, but it also depletes through enhanced antibody-dependent cellular cytotoxicity. And this was a dose-finding phase 2b study with 3 doses. And when you look at change in ESDI, there is certainly a suggestion as a dose effect, with the highest dose showing a statistically significant improvement in the ESDI score. One thing you'll see quite well here is that there's a very high placebo response when you look at the proportion of patients with 3-point or more improvements. So 61% of patients in the placebo group seem to be responders, but almost 90% in the highest dose group. So showing some suggestion of efficacy based on this ESDI. The other thing that's quite nice about the lanalumab study is that stimulated salivary flow also increased, again with suggestion of a dose-dependent effect, with the highest changes seen with the highest 300 milligrams dose. But where it comes unstuck, again, is symptoms. And this is the ESPRI score, which is simply the mean of dryness, pain, and fatigue, each measured on a 0 to 10 scale. And there's no difference between any of the treatment groups. And again, quite a large placebo effect. So a reduction in score is good. FACIT-F is a measure of fatigue. Higher scores are better with FACIT-F. And again, you can see that all the groups rise with no clear distinction between any of the treatment arms and no differentiation from placebo. So this is a problem. And the question is, why is this such a problem? And it is a problem because for patients, symptoms are the biggest driver to poor health-related quality of life. So if a drug is not improving symptoms, that's fairly problematic. But there may be particular aspects about this trial which may be contributing. So even in the placebo arm, the patients got a dose of methylprednisolone at the start of the study. The reason that was given was because there's a high incidence of injection site reactions. They wanted to avoid unblinding. So patients, even in the placebo group, would have had a steroid dose at the start. Maybe that gave patients a sense of well-being, and maybe that induced placebo responses. I'm not certain about that. The other aspect is maybe time will help here. So at the end of this week 24, which is the primary outcome of the study, patients went on to an extension, and the placebo patients were switched on to active drug. And the highest dose group, half of them went on to placebo, and half of them continued. And the patients who switched to placebo had some loss of effect on symptoms, and the placebo patients who had seemingly responded got further response when they got switched onto active drug. So maybe if you run this study over a longer period of time, you may start seeing some differentiation from placebo, but it's a bit too early to be sure of that. But as you're well aware, Vasco told me that you're involved in this. There's a Neptunus program which is seeking to answer that particular question over a 48-week period in two very large, for Sjogren's anyway, very large phase 3 studies. Now, the other way you could approach depleting B cells from tissue is to use a combination of belimumab and rituximab. So, as we sort of alluded to, rituximab is very good at depleting B cells within blood, less good at doing it within tissue. But belimumab has an interesting effect because if you give a patient belimumab, it will reduce the number of naive, activated, and plasma B cell subsets. But in the peripheral blood, it will increase the number of memory B cells. And one of the reasons it may do that is through mobilizing memory B cells from tissue into the peripheral blood. It also changes the stringency on B cell selection, making it less likely that a patient will develop autoreactive B cells. And so this is a GSK-sponsored study, and they had, quite a nice design here in some respects. So what they did is they gave belimumab in this combination group. So that would theoretically mobilize the B cells from the tissue into the peripheral blood. Then you give them a course of rituximab to deplete them, and then you continue the belimumab to try and prevent repopulation. And they compared that to belimumab alone, to rituximab alone, and to a double placebo. And in terms of the hypothesis of whether this can give you better B cell depletion, it's possible that yes, it does. So if you look at the combination group, which is here, then there seems to be a marked reduction in B cells in the tissue post-rituximab. And that was less pronounced when you looked at any of the other disease intervention groups. When you looked at the ESDI, so this measure of systemic disease activity, the study really wasn't powered effectively to compare the individual groups. But there just seemed to be a difference from placebo in red, but no distinction actually between any of the individual treatment arms. There's a suggestion that the combination group may improve saliva flow more than the other arms. Again, it's not really powered to look at this. And that's unstimulated, and this is stimulated saliva flow. Again, it's showing a similar pattern, although the baseline is different. But again, this problem of symptoms, no real distinction between any of the arms in terms of symptomatic improvement. So other ways you could potentially think about targeting B cells is not just by binding to BAFF, but also by blocking APRIL as well. So BAFF, which we've been mentioning a few times, will bind to the BAFF receptor, as we've alluded to. That's the receptor targeted by lanalumab. But actually, BAFF also binds to two other receptors, the TACI receptor and the BCMA receptor. And those two receptors are also bound by APRIL. APRIL is a cytokine that may well have an effect on later stages of B cells and also pre-plasma cells and plasma cells in terms of inducing their survival. So telitacicept is a TACI receptor that's been bound to the FC region to prolong its half-life. And it's a drug made by a company within China. And they have launched a phase 3 study in Sjogren's. Interesting, at the last ACR, there was some data on lupus. So this is not a Sjogren's study, it's a lupus study. The outcome was SRI-4 and showing really an extremely impressive effect size. So this is a multi-center study, quite a large study, run across multiple centers within China, but not outside of China. They're now doing that. But at last EULAR, a few weeks ago, they also presented some data on a small Sjogren's study. This is the phase 2 Sjogren's study. And up here, again, you see there's a difference now between placebo and the two active telitacicept arms. A couple of points I'd make about this. Firstly, this is reduction from baseline. So they haven't shown you the week 0. The week 0 would be showing you 0, and this is change from baseline. So the actual effect or reduction in ESDI is not very large when you compare it to a study like lanalumab. What is really different about this study is the placebo response. So actually the placebo response isn't there. In fact, if anything, the placebo group does worse over time rather than better. That's quite different to a number of other studies that we've seen in Sjogren's. And I don't know why that is. And, I don't know whether it's genetic, I don't know whether it's ethnic, I don't know whether it's cultural, I don't know if it's the quality of the people who are setting the ESDI score, whether it's patient expectation. But there are a number of studies coming out of China showing much lower placebo responses. And of course, the lower your placebo response, then the better your chance of seeing a clinical effect on a drug with a drug that works. And lowering placebo responses is one of the biggest challenges we have in clinical trials, not just in Sjogren's, but in many other diseases. So again, there seems to be some improvement in fatigue scores. And so this may look promising. Okay, another way you could target B cells, of course, is Bruton's tyrosine kinase. So it's targeting the signaling pathway below the B cell receptor. And there are a number of drugs which have been developed to block BTK. They've been studied in all sorts of B cell mediated autoimmune diseases. And actually most of them have failed or not looked very promising. But this is a drug, remibrutinib, that's been developed by Novartis. It's a covalent BTK inhibitor with high selectivity, and it binds to an inactive conformation of BTK. And interestingly, the data suggests there's also benefit on ESDI scores. But the benefit is mainly seen when you look out to week 24. When you go out to week 12, certainly the lines are beginning to separate, but it's much less clear cut. And a lot of phase 2 studies have run out to 3 months. Some potent drugs maybe have shown efficacy, some other drugs have not. And the question is whether it's simply been that they've not been studied for long enough. And so that's another lesson that we may be learning about clinical trials. You need to run them long enough in phase 2 to see effects in a condition like Sjogren's. Again, also some improvements in saliva flow with this BTK inhibitor. So the question, an interesting question is actually what are autoantibodies doing in Sjogren's? And I think there's a little bit of circumstantial data suggesting that autoantibodies may contribute to the pathogenesis. How much, I think, is yet to be determined. But this particular study may go some way to answering that. So nipocalimab is a drug that was developed by a company called Momenta, and Momenta were bought by Johnson & Johnson or Janssen for about $6.5 billion US dollars. And it's got some interesting phase 2 data in myasthenia gravis, but Janssen are trying to recoup their investment by studying this in almost every autoimmune disease under the sun where B cells may be involved. And how this particular drug works, it works by blocking the neonatal Fc receptor. So immunoglobulin, the reason IgG has such a long half-life is because when it's taken into cells, it binds to, in the endosome compartment, it binds to the neonatal Fc receptor, which prevents it from being degraded or prevents it from being destroyed. It can then be recycled to the cellular surface and released. So it's this protection against degradation which gives IgG its prolonged half-life. But this is a system which you can saturate or you can block it. And the nipocalimab is one of many drugs which are now being investigated, which will bind to the neonatal Fc receptor, block this interaction, and lead to the degradation of IgG. And I think the results of this particular study is a phase 2 study. I think will be really quite intriguing to know whether this does anything at all. Okay, shifting gear very briefly. Mentioned right at the start that type 1 interferons may well be important in pathogenesis of Sjogren's. Certainly you see very high type 1 interferon levels. It correlates with autoantibody formation. It correlates with the levels of IgG. And certainly it probably has a contribution to driving B cell hyperactivity. But of course, we've got anifrolumab, which is a drug which very effectively blocks type 1 interferon by binding to the type 1 interferon receptor and has shown efficacy in lupus. And this is an interesting study that's been run by Hendrika Boetsma in Groningen called the ANISE study. It's going to be it's just a very small study, 30 patients randomized 2 to 1. And the primary outcome is going to be a composite score involving the ESDI, but also various other domains. We may touch on that later. Again, I think this will be quite an intriguing study. I'm quite looking forward to seeing what this will actually show. And one of the reasons why I think it would be quite intriguing is that although we know that type 1 interferons are very elevated in patients with Sjogren's, they're not actually associated with symptoms. So in fact, if some studies suggest an inverse correlation, so the more type 1 interferon, the less symptoms you got, which is intriguing. And we know that hydroxychloroquine and also filgotinib can reduce type 1 interferon signature in patients with Sjogren's, but haven't seemed to improve symptoms. And in SLE, when you actually look at the symptom burden, there's a very interesting causal analysis study where they suggested that the effect on symptoms in Sjogren's is indirect. And what that means is that the modeling suggested that when you gave the treatment, that improved systemic disease, it improved or rather reduced the amount of steroids that patients were taking. And it's those changes in systemic disease and changes in steroid use, which then were associated with a reduction in pain, then a reduction in fatigue, and then an improvement in mood. So the treatment didn't directly affect the symptoms, but it was indirect via changes in systemic disease and steroid use. And if that pans out, that follows through in Sjogren's, it'll be intriguing to know whether that will also work on improving symptoms in Sjogren's if there's not a direct effect. So I think this is going to be quite an interesting study. Okay, so moving on to another way to think about targeting B-cell hyperactivity, and it's through blocking co-stimulation. This is something we've been very interested in for a number of years. So looking at the CD40 pathway, and this is really an important pathway at multiple levels within the immune system. So the CD40 pathway will license or activate antigen-presenting cells such as dendritic cells, and what that means is that a licensed cell, antigen-presenting cell, can then activate T cells rather than make them inactive. So an unlicensed dendritic cell presenting antigen to a T cell that recognizes the antigen may switch off that T cell rather than activate it. But if you have licensed or activated the dendritic cell beforehand, and CD40 pathway has an important role in that, then the dendritic cell can then activate the T cell. It also has really critical roles in B cell function, including proliferation, antibody class switching, and germinal center formation, which, as I showed you at the start, seems to be quite important in the pathogenesis of Sjogren's, and is very commonly seen in our patients. And Novartis did a little bit of work a few years ago looking at NOD mice. So NOD mice are a model of type 1 diabetes, but they also can be used as a model of Sjogren's because they develop a focal lymphocytic cyanitis within their glands. And this is looking at the submandibular glands of mice, NOD mice. Oops. And what you can see here is the areas of T cell infiltration and B cell infiltration. And yet, if you look at the antibody-treated group, this is an antibody to CD40 ligand in this particular case, it seems to obliterate the focal lymphocytic cyanitis. And this was a drug that was given after the onset or after the age at which mice would typically have developed this already. So this is really quite intriguing that this could be quite a useful pathway to target in patients with Sjogren's. And we were involved in a phase 2 study quite a few years ago now, which looked at ESDI as the primary outcome in a drug that targeted CD40 that we now call lanalumab, used to be called CFZ533. And this is a blocking, non-activating antibody which has an Fc silent region, meaning it can't activate complement and it won't bind to Fc receptors. So it has an entirely, a purely blocking function. And we saw quite a nice reduction in ESDI scores at week 12. But the other thing that was interesting is that although it wasn't powered to look at symptoms, there were some trends to improvement in symptoms, trends to improvement in fatigue. So going in the right direction. I think you've been involved in the, yeah, you've been involved in twin study as well. So this is a study which is quite interesting because it's got 2 cohorts of patients. It's a dose-finding study, a phase 2b. And there's a systemic disease group with a raised ESDI score, which will use ESDI as the primary outcome measure, but also a second cohort of patients, which have a low ESDI score, which is the majority of our patients, certainly in my experience anyway, but which have symptoms in terms of fatigue or dryness. And they had to have some biological activity as well. And the study is completed, and hopefully there'll be data out in the next few months from this. But there's another drug. In fact, there are at least two other drugs, or two or three other drugs in Sjogren's targeting the CD40 pathway. And datodalibep is an interesting molecule. So instead of binding to CD40 like iscalimab, datodalibep binds to CD40 ligand, and it's a non-antibody structure. So tenascin is a molecule, tenascin C is a molecule which has immunoglobulin folds. So you can mutate it to give it specificity to bind to any protein. So datodalibep has two tenascin C, modified tenascin C molecules bound together, and then it's bound to human serum albumin, which is just there to give it a longer half-life. And they took a very similar study design to the iscalimab study I just mentioned. So they've got a systemic disease group, and they've got a low systemic disease group. And they did a press release suggesting that they met their primary outcomes, and there was some data at EULAR. And this is the systemic disease cohort, looking at the change in ESDI score. And this is quite interesting. So it differentiates between the placebo group and the active arm. That's at kind of week 24. Interestingly, if you took this study at 3 months, the effect would be a lot less marked. Again, it goes to the point we need, for some drugs, you may need a longer study length to show effects. But there's also a suggestion, some trend to improvement in symptoms in the systemic disease group. Not a large effect, but there is a suggestion of symptom improvements, both in terms of the ESPRI and also this measure of fatigue. But when they looked at the high symptom burden, low systemic group, and this is what I find quite intriguing, there's really quite a large discrimination statistically between the active arm and the placebo group. And combined with the phase 2 data I showed you earlier with iscalimab, where there's quite a strong trend, I find it interesting that drugs targeting the CD40 pathway are sort of all showing the same sort of direction of travel, improvement in symptoms, which is what we haven't really been seeing in many of the other drugs studied so far. So this is really intriguing. Maybe, I don't know whether there's something that's CD40 specific or whether we're just targeting a bit of the pathogenesis that is very much more central to what's driving Sjogren's syndrome. So another way you could affect the way that T and B cells talk together is through preventing or altering antigen presentation. So there is a strong HLA class 2 association with Sjogren's syndrome, and HLA class 2 present antigen that's taken from the outside of the cell. So this is, in this case, that's a bacteria, but it could be an immune complex that's taken into the cell. And then you get these phagosomes, and then you've got the HLA within that. And the HLA, the HLA which joins that, the HLA is initially presented or was protected from binding peptide by an invariant chain. And then the invariant chain is gradually nibbled away by a series of enzymes until you leave just the clip, or just the clip is there. And then the clip is removed by something called HLA-DM. And once the clip is removed, it can bind peptide from within the endolysosome and then present that to a T cell. But there is this series of enzymes which gradually remove this invariant chain. And there's an enzyme called cathepsin S, which is thought to be non-redundant in some antigen-presenting cells, maybe not all. And there's various companies that have developed cathepsin S inhibitors. And there is a little bit of animal model data suggesting that could be beneficial. So this particular animal model of Sjogren's looked at a variety of cathepsin inhibitors. The one in black is the cathepsin S inhibitor. And this suggests that there's a reduction in the histological changes within the salivary glands, and also that there's an improvement in saliva flow. If you look at the black lines there compared to the placebo groups. And also a model in the MRL, so that's a model of lupus, suggesting that with a cathepsin S inhibitor, there's a reduction in anti-double-stranded DNA antibodies and also a reduction in complement deposition in the kidneys, which relates also to improvement in kidney structure and less damage taking place within the kidneys. So this going a few years ago, I think Vasco, you're involved with this. There's lots of frustrations around this particular study and also the publication as well, but it has finally, something's finally come out. So this is a study that was ran over 3 months of patients being randomized to cathepsin S inhibitor or to placebo. And the drug did have a pharmacodynamic effect. So this is cathepsin S mass. And if you inhibit cathepsin S, then your cathepsin S mass increases in the periphery. So it shows that the drug did engage. So it seemed to be doing what it's meant to do. And then when you look, though, at the systemic disease activity or the symptom burden, again, this has changed from baseline and they've not shown week 0 on these graphs. So it should start from up here and then go down. Again, the lines go down in both treatment arms, but there's no clear discrimination between active drug or placebo. And the number of responders is almost identical between both arms, both in terms of systemic disease, but also in terms of symptoms. And yet, when you look at IgG and IgM, both of those went down in the cathepsin S inhibitor group. And also actually rheumatoid factor improved as well. So this drug is having biological effects, but you're not seeing clinical effects. And I don't know why that is. You would think that this would have some effect if you're inhibiting antigen presentation to T cells. Presumably, there's still a role for T cell dependent B cell hyperactivity in Sjogren's. So why is this drug not working? Is it simply that maybe there's a degree of independence from T cell activation? Is it the study didn't run long enough? Maybe if you've got a modest effect and you ran this study over 6 months, maybe you'll start seeing an effect. Or is it like maybe some studies in rheumatoid where you can see changes in IgG levels, but no change in clinical activity? I don't think we know yet why that is. Okay, and very lastly, what I'm going to finish up with is moves within an IMI-funded consortium to try and improve the disease outcome measures for clinical trials. So there are recognized problems with the ESDI. It's difficult to measure some domains. It's a blunt tool. It's got this odd distribution statistically. And symptoms are also problematic. And both of them have high placebo responses. So what this group called the Necessity Consortium did is that they took originally the rituximab trials, which failed in their primary outcomes, but with showing some suggestion that maybe they are working or maybe there's a modest effect. So they took all the data from those trials, they found a responder population, and then identified which factors differed between the responder population and not. And then they did a lot of stakeholder engagement. So they engaged with patients, they engaged with clinicians, they engaged with industry to try and prioritize the various domains. And they selected 5 domains that they thought might be dynamic. And they developed a composite. So if you improve in systemic disease, then you get 3 points. Improve in symptoms, you get 3 points. But they also looked at tear gland function, salivary gland function, and the biological domain, and a candidate star response is 5 or more points. So one issue I would point out with this is the already said that the ESDI has a problem. The ESPRI, a measure of symptoms, may also have a problem, may not be ideal. So this composite actually keeps those more or less intact. So it hasn't reconstructed them, but what it's done is it's spread the risk by looking at across multiple domains instead of just one domain. So this still needs validating, and it's going to be validated, or is being validated in a trial called the Necessity Trial. And this is taking old drugs, so leflunomide and hydroxychloroquine in a combination, which interestingly, in a single center study in Holland, did show some difference on ESDI at week 24. It's also going to compare it to mycophenolate and hydroxychloroquine as a combination, which hasn't been previously studied, and also compare that to double placebo. And that's been tested in a large number of centers across Europe. It's been led by Xavier Mariette in Paris, a number of UK centers taking part in that, hopefully when we get the approvals to do so. And that's where I'm going to leave it, other than just say my conclusion. Sjogren's disease, and I'd advocate for it, is a disease with unmet needs. We need to develop drugs for Sjogren's. There's ongoing interest in targeting B cells and co-stimulation, and the CD40 pathway is showing a lot of promise with at least 3 drugs in active development stages. There's ongoing work on the outcome measures, and we don't quite know yet what the role of composite outcomes are. I could talk to you later, but there's interesting interactions with the regulators around these composites, and they may not be the final word on outcome measures, and there's still more work to be done. There are issues in many trials with high placebo responses, and what can we do about improving those? Also issues around disease duration. Maybe patients with shorter disease duration may do better in clinical trials. Also issues around concomitant medications, which have bedeviled many trials in lupus. And then what patient populations do you put into these trials? So many of the studies have looked at systemic disease, and yet the majority of our patients don't have enough systemic disease to go into a clinical trial, and yet have poor health-related quality of life. Should we be developing drugs for them? If so, what are the outcomes that we should be using? Again, the whole issue of symptoms, we've seen some nice data from CD40 pathway targeting, but in other studies, they've not shown so much improvement. Are there better ways of measuring symptoms? How do you measure quality of life in Sjogren's? Do we use existing measures or do we develop new measures? And then how do we develop efficient phase 2 designs? How can we optimize those in a way that will give you the best signal to understand whether to take it forward into phase 3, and how long should those interventions last? So those are some of the key questions, I think, which there are today. And some thanks to colleagues, which I work with very closely at Birmingham, and happy to answer any questions.
Thank you. Thank you, Ben. Amazing talk. Questions?
Thank you. So I was wondering how is the situation regarding biological markers of response, surrogate endpoints that would be of valuable in a clinical picture where you have in most of the clinical trials a high placebo response. And one of the hypotheses that I was imagining in my mind was to take advantage of B cells, because most of the B cell work that was shown there was basically related to the presence or absence of cells. But coming back to the experience in synovial tissue, although during years we were looking at cells, in fact, the single most interesting observation, and regarding by coincidence B cells, was the expression of B cell related proteins, and not exactly the amount of B cells that are there. For instance, to differentiate between the responders to tocilizumab and rituximab in a recent trial. So have this been done, looking at the level of expression per cell in the context of salivary gland biopsies?
So if I understand you correctly, are you talking about single cell data or
yeah, for instance, single cell.
Yeah, so I think that's the, yeah, so I didn't talk about biopsies here because there wasn't really enough time to go into it. I agree. So we've done a lot of work over the years in looking at very basic outcome measures within tissue. And there's so much spread of data that you would actually need quite large numbers of patients to actually see signaling, even if the drug works. So we're very interested in actually looking at single cell sequencing as a potential outcome. There are issues around that in terms of doing it to good clinical practice and validating that. But we're actually doing it at the moment in, as mentioned to Mathilde, we've got a basket trial running at the moment where we're looking across diseases, and we're looking at the single cell level to try and look at the activation status of T cells and also B cells within this live gland tissue to understand whether we get a signal of efficacy in a smaller number of patients. So yes, we're actively exploring that. I think there is definitely a rationale to do that, but it's an untested concept at the moment.
Questions? So I think this was really interesting to see that even though we're focusing not a lot of pathways, I mean, the same cells over and over, B cells, T cells, and we get so many molecules. And I think a talk like this 10 years ago would have been unthinkable. And it's really exciting to then see the trials coming into good results. But coming to a point that you raised, especially because I think this is actually very different comparing to the lupus patients, where you do see, I think, a more direct correlation between symptoms and disease activity. I mean, lupus patients, when they're doing better, if there are no severe comorbidities, they say, yes, I feel better. Sjogren's patients, they come to us, we say, oh, the blood tests are better. And they say, okay, but I feel terrible anyways. And so I was, and I don't think that's a hypothesis that there was in lupus, that this could be an indirect effect. I find it hard to demonstrate in Sjogren's because first off, you see the two populations that you have with a high SDI, and usually these patients have a much lower ESPRI, so they have more severe active systemic disease, but they do not complain so much, and vice versa. And so, and this is very intriguing. I usually say that on the other spectrum, we have, for instance, axial spondyloarthritis, where patients and fatigue and inflammation is very, very well correlated. And I think we're a bit biased by that. But here, and as you said, some markers even say that more inflammation equals less fatigue. And so it's really confusing. So do you think we will be able, what is driving these, what is the uniqueness of Sjogren's in this, and if it's biological or any kind of pathogenically differences, or may it be that patient-related outcomes in Sjogren's may reflect a lot of damage and things that maybe cannot improve?
So I think we could talk a long time around this, probably. So I think there are multiple problems. Firstly, if you look at the ESPRI score, it's dryness, pain, and fatigue, but the pain is limb pain. So, a patient who is 60 years old, who has osteoarthritis of the knees, what are they actually scoring in their pain domain? And that's the one which changes often is most difficult to change with an immunomodulator. So I think it's a problem with the scores. I think there may also be, I mean, even with rheumatoid arthritis, if you take a drug like anti-TNF, we know it improves fatigue. We know that patients feel better after they take it. And yet, at a group level, the fatigue will not go down to the baseline of a healthy control population. So there's something still going on that's driving symptoms. There may be counter-regulation. So there may be biological systems, maybe neurological systems, which are aiming to switch off certain types of inflammation that are driving these symptoms. And if that's the case, how long would it take to improve? Maybe a long time, or could you improve it? I don't know. I was very negative about symptoms and the problem until we saw some of the more recent CD40 data. And I think we're seeing consistent effects that actually you can get symptomatic improvement. So maybe it's just that we haven't had drugs that have really kind of worked. But I think also is that we talk about this systemic disease and this non-systemic disease. Even if you take a patient with so-called non-systemic disease, they actually have systemic disease. They've got skin dryness. That gets better with some interventions that we've used. So you will find subtle, lymphocytic infiltration within the skin if you look hard enough for it. So it's all systemic disease. It's just that we can't measure it easily in some patients. And I think maybe we just haven't had, I think it's a combination of things. I think it's biology. In some patients, maybe psychology, but I think primarily it's biology. I think it's the outcome measures, and it's not having drugs that are good enough. But it's a complex problem, you're right.
And related to that, something that I think you did not touch because it's also very extensive, which is this notion of the different clusters of patients, both in terms of symptoms and how this, and this has through then translation into biomarkers, gene expression, and so on. And there was some data presented at the Sjogren Symposium showing, for instance, 100% response to rituximab in one of the trials in one of the clusters, and there was really a huge difference. And then when you lump all these clusters together, you get no effect. could that be a different reason and something that we are also seeing in rheumatoid, for instance, the same clinical phenotype, but then a lot of it heterogeneity in terms of the pathways that are more active?
So you're referring to work that came out of Newcastle and also has been replicated in some other centers as well. So if you take dryness, pain, and fatigue, and anxiety and depression, and you cluster patients, you get different groups. And there's this concept, there's a dryness dominant fatigue, which may have more B-cell activation, and maybe the rituximab responses are better in that group. I think you have to be very cautious in the rituximab data because it is a post-hoc analysis. It's a very small number of patients. Actually, they could have picked many other outcomes, but it's a selected outcome of saliva flow. So other outcomes, I'm sure, wouldn't have been quite as impressive as that. So it's very post-hoc, so you've got to be very cautious about that. I find it very interesting, but I think it'll be something that's done at the group level. I doubt that you'll be able to take a particular pattern of symptoms in an individual patient and necessarily understand really whether that patient ought to receive drug A or drug B. I find that more of a difficult concept because these are a continuum.
Yes.
In terms of the scores.
But do you think that they may reflect biological differences?
Possible, yes. Yeah, I think it's possible. But probably weak effects actually, rather than, this is a really distinct cluster from, cluster A here is very distinct from cluster B. I'm sure there must be some overlap between those.
Okay, so thank you. I think we can close now. Thank you very much. It was very, very interesting. And we'll meet again soon. Thank you.
Thank you very much. Thank you.